Hello, my name is John Urbans. I'm President and CEO of Greater Fort Wayne, Inc. And I'd like to thank you for joining us today on the Roadmap to a Healthy Reopening webinar series. Today, we're going to be focusing on religious institutions. I'd like to thank our partners in this endeavor, Parkview Health, the Northeast Indiana Regional Partnership, and the Allen County Department of Health. Special thanks to Dr. Deborah McMahon and Mindy Waldron at the Department of Health for their great leadership through this pandemic. Also, Heather Schegler at Parkview and the staff here at Greater Fort Wayne, Inc. and the Regional Partnership. A great deal of time and effort has gone into bringing this series to you. And we're very proud to be able to bring this critical information to our business and religious community. Just for some housekeeping notes, we will be taking questions and answers in the second half of the webinar. The Q&A tab down at the bottom of your screen will be a great way for you to submit questions. After the seminar, you will receive an email with a survey. You will also receive a second email that will have a copy of the slides and a link to the recording of this webinar in case you need to use it later. I'd like to thank participants for submitting their questions in advance. These served as a guide for the Parkview team to develop the content and help shape this presentation. While you may not hear your specific question asked, we hope that this information will address your most pressing concerns. I'd like to go ahead and introduce the Parkview participants. We have Jolynn Succo, the Chief Innovation Officer. We have Dr. Jeffrey Board, Chief Safety and Quality Officer. We have Dina Jackway, Chief Community and Human Resources Officer. And Dr. Mike Knipp, Parkview Total Health Chief Medical Officer. Jolynn, I'm going to go ahead and turn it over to you.
Fantastic. Thanks, John. So thank you so much for joining us today. As John said, I have the privilege of serving as the Chief Innovation Officer for Parkview Health. And I really want to start by saying thank you for all that you have done for us as we've been there for you. Thank you for staying home to slow the spread of COVID-19. Thank you for running many of your programs online. We have been overwhelmed by the generosity of our community. We've received hundreds of cards for coworkers and patients, distributed thousands of meals from local restaurants, and we're moved by the flyover of the 122nd Fighter Wing and the socially distanced prayer vigils at many of our locations. We are really humbled by your generosity. I also want to share a little bit with you about how we're doing today. So if you look at this slide, as you can see, we have our COVID impact meter. We are not in a crisis, and fortunately, we have not been in crisis since we opened our incident command 60 days ago, but we're cautious. We have been able to handle the surge, and we are prepared for the future. We've been taking care of patients since we opened our command center, and in the last couple of weeks, we're beginning to see our number of COVID positive hospitalized patients plateau. We're beginning to restart elective surgeries on Monday in a very slow phased, gradual fashion. And more importantly, we're seeing people come back to the emergency room, which gives us a lot of hope. Some people have delayed really needed care. And we talk about a surge to COVID, but we also are seeing a surge of people who've delayed really important care and things that they need for their health. So we, like you, are beginning to think about how we begin to safely open the parts of our business that we've suspended due to COVID-19. But we're also really taking a step back to say, how is the world different today than it was 60 days ago? As we think about this, there are really important considerations that are going to guide our actions. First, COVID is here. It is going to be in our community. We'll continue to have positive cases. The most optimistic estimates for a vaccine are that it's 12 to 18 months away, and we have no herd immunity. We expect it's going to be a little bumpy as we reopen Parkview as well as we reopen Northeast Indiana. And we really want to keep these surges as low as possible. We're also operating in a world where the information we have is evolving and dynamic. We are implementing safe practices that will help our coworkers, customers, and community. And we know that Challenges like COVID cause us to think differently, innovate, and emerge even stronger. So we're spending a lot of time thinking about how to open in the absolute safest way. As the community, you have been so generous with us, and today we want to return some of that generosity to you by sharing what we are learning and doing. You're going to learn more about our free service offerings later in the webinar, but one thing we've created is a website to share what we've learned and what others are doing in a variety of areas. This will be a living document that will evolve as our dynamic situation takes shape. We have it full of workplace, church, and school considerations. We've also established a hotline with a one-day turnaround where you can answer questions from our subject matter experts about what we are doing. We want to stay in dialogue with you, our community, so that we can all open safely together. With that, I will turn it over to Dr. Jeffrey Board, who will share more about our approaches to how we keep our workplaces safe.
Thank you, Jolynn. I'd like to begin with thinking about your workplace, which in a religious or spiritual organization is going to be a church, a mosque, or other religious establishment. So think about that physical building where you have people congregate, where you provide services to members of your faith community. Think about your building and how people enter and exit. Think about common areas, how your sanctuary is configured, your seating. Think about where your staff work throughout the work week if you have part-time or full-time staff supporting your religious organization. An important consideration as we think about how to return to the activities in a world where we have to coexist with COVID-19 is the concept of community spread. In the United States, COVID-19 is in the community spread situation. And that means that it is not limited to one place or area. The source cannot be pinpointed, meaning that if someone comes to one of our hospitals or clinics, we diagnose them with COVID-19, generally we are not going to be able to pinpoint the source of the infection. We do not know where that individual might contract the virus. Everyone in the population is potentially susceptible to COVID-19. This is a novel coronavirus. There is no established immunity in the human population, and therefore all of us are potentially at risk to contract COVID-19. That being said, those in our community that are older adults, 60 years of age and older, those with chronic health conditions, are at greater risk for severe illness if they do contract COVID-19 and are going to be more likely to require hospitalization or even ICU care. We need to keep this in mind when we think about those in our community or those people that you serve that may be more vulnerable to more severe illness from COVID-19 and how best to protect them. A fundamental framework that is extremely useful in this consideration is what's called the hierarchy of controls. This is a foundational framework from occupational health and safety, and it is a tiered approach to building a safety plan for your organization. And it begins at the very top with elimination. That's physically removing the hazard from parishioners and from staff members and employees. So a good example of this in the religious community is holding virtual online religious services. This eliminates the risk of transmission to a faith community. Next comes engineering controls. So these are physical barriers that can be set up to isolate people from any particular hazard. So think about different things you can use to physically isolate people from a given hazard. Next is administrative controls. So these are how we do particular tasks and workflows, employee or parishioner behaviors to minimize the risk of spread. This is things like not shaking hands, staying 6 feet apart, paying close attention to hand hygiene and having hand sanitizer readily available, practicing respiratory etiquette, and maintaining appropriate social distancing with interactions. Finally, the last line of defense is personal protective equipment. It's very important to select the right type of personal protective equipment for the task at hand, and also make sure that anyone using the personal protective equipment is properly trained on selection and use, particularly wearing and removing personal protective equipment. The CDC recommends all businesses consider the following controls. Think about engineering controls in your building and your building ventilation system. Support respiratory etiquette and hand hygiene for employees, visitors, and members of your faith community. Make sure that you identify opportunities to practice routine and enhanced cleaning and disinfection, particularly with high touch or common use surfaces. This may be something where you need to engage members of your faith community to help you assess to keep your organization and your areas safe for use for religious services. I want to spend a few moments talking about testing. There's been a lot of attention about testing in the media, and it can be very confusing. There are two main types of testing that are currently available clinically. Antibody testing is done through a blood test, either a blood sample drawn from a vein or a finger stick with a small spot of blood. These tests are useful to do what we call population surveillance of past infection. This is currently being carried out by the Indiana State Department of Health in cooperation with the Indiana University School of Public Health. Right now, they are sampling populations of people in every county within our state, and they will be able to evaluate the spread and prevalence of prior COVID-19 infections on a statewide basis and be able to understand that both on a community level and on a regional level. This type of information can be collected periodically and can help inform things such as public health measures, as well as policy decisions at the local, state, and federal level. Antibody testing also has a role in research. There are some very important limitations with antibody testing. At this time, specifically with COVID-19, it is unknown if antibodies are in fact protective, meaning that if someone has a positive COVID-19 antibody test, we really do not know for sure whether or not they would be immune to reinfection. We also do not know whether or not that person could still spread the virus to other people. The Food and Drug Administration, in an effort to quickly get as many tests available and brought to market as quickly as possible, waived many of the standard requirements and evaluation steps for diagnostic testing. As a result, many tests that are currently on the market have not had any formal evaluation or scrutiny by the Food and Drug Administration and have not undergone any type of extensive or detailed validation testing by a clinical reference laboratory. As a result, unfortunately, many tests currently available on the market may be inaccurate or unreliable. And because of this, these types of tests are totally inappropriate to use as broad screenings for return to work or access to a building decisions for individuals. Next is PCR testing. This is the nasal or nasopharyngeal swab that we collect in order to diagnose someone with COVID-19. This test actually detects RNA from the virus in the back of the throat or nasal secretions. This is used to diagnose people with symptoms. When people do not yet have symptoms, they may not be shedding enough virus to be detected using this technique. So there is risk of what we call a false negative test. Someone may harbor the virus, but if there is not enough virus detectable in the back of the throat, the test result may be negative, even though they may later become infectious. Also, this test only gives you one snapshot in time. It tells you whether or not virus is present in the back of the throat at the time the patient is swabbed. So if a person has a negative PCR test on Monday, they could still later become exposed and become infectious to others at a future time. We use the hierarchy of controls framework here at Parkview Health. We call it more than a mask. And that helps people think about all of the hierarchy of controls to build a comprehensive safety plan and not rely solely on personal protective equipment. Briefly, some examples of how we use the hierarchy of controls. Elimination. We have massively increased the use of virtual health. So in the last week, we had over 6,000 virtual health encounters with patients in our community. This, using telephone or video-based visits, allows us to safely provide care and eliminate any risk of transmission of the virus to vulnerable patients or to coworkers. We also, whenever possible, hold virtual meetings for the same reason, to protect our coworkers. Engineering controls in healthcare are commonly used. Those can be things like air handlers or negative pressure rooms, plexiglass barriers, or other types of physical controls to isolate people from hazards. We frequently also use administrative controls, such as limiting the number of coworkers in an office, using training to manage cough etiquette, social distancing, frequent use of hand hygiene, and frequent cleaning of high-touch surfaces and areas and workspaces. Finally, PPE. It is very important to make sure that the right type of PPE is selected and that anyone using PPE is properly trained on use, particularly on putting the PPE on and removing it safely. Next, I'd like to turn things over to Dina Jackway, our Chief Community and Human Resources Officer.
Thank you, Dr. Board. So I appreciate you talking to us about the hierarchy of controls and really how to keep your workspaces and your workplaces safe. I mean, even today, being able to put on this webinar, we think about the administrative controls that we put into place. We're in a large room, we are 6 feet apart, we're hand sanitizing not only before we're coming up, but after we're done. We're making sure that we're putting all those controls into place just to be able to put this webinar on for you. So as we recognize that over the last 50 to 60 days have been feeling like one local CEO put it, like you're flying a plane and you're trying to fix it at the same time. We know that our world has changed, our community, organizations, and certainly the people that we're coming into contact with. And when we think about people for today in particular, it's not only your coworkers that are working within your religious organizations and your team members, but it's really about your members, your congregants. It's about building users who might use some of your space, might be local nonprofits that you're partnering with. When you think about people and the things we're going to dive into, think about it very broadly. The CDC put out some great feedback related to how to help better support organizations in keeping people well. And so I want to share with you some of those best practices. The first of which is identifying a workplace coordinator. It's really important because for many of those on the phone, you probably don't have an HR department. You don't have that central point, but you definitely have individuals who not only in your members for your organizations, but also your coworkers who are asking questions. Fears are high. They want to understand and know more. So having that central workplace coordinator that is going to be the central source of truth and being able to keep up with things that are changing and guidelines changing so fast and furious. So having that central source is important to be able to communicate out effectively to everyone that you need to. Education is really important as well. And why that's important is because as people have more fears, coming back into, say, gatherings and coming back into the community, you want to be able to explain why you're making the changes that you're making. Because as fears are high, you're going to leave them with questions if we don't explain, here's why we're making this change. I mean, even in coming and gatherings and coming into churches, you're going to have to make a lot of changes. And if you're explaining to your members why you're making those changes and tying them back to where those sources are coming from, it's going to be really important, and we'll have more and more people engaging. You want to consider your social distancing policies, and Dr. Board talked a lot about that, and Dr. Nip will get into that as well. But consider you're vulnerable, and whether it's your vulnerable team members who perhaps may need some accommodations as they're engaging and coming back into the workspace, but you also have members that have vulnerable conditions. And so how you're going to be able to engage with them and provide services to them will be important, because putting everyone together may not be a reality. On the staffing side, we feel as though flexibility is the key. And some of you have smaller teams than others, but really being able to be flexible, and it goes both ways. It's not only us asking for their flexibility for team members. You might be doing work that you weren't doing before. You might be cleaning those high touch areas on a more regular basis, and perhaps that wasn't part of your job before. You might be doing some things different, and we're asking for flexibility. But at the same time, we need to provide flexibility to those coworkers. They may not be able to work the same hours they once did. They may not be able to be in the office as much as they were before. And why is because childcare could be a barrier. There could be someone who is ill at home. There could be, they're taking care of their parents. And so for us to be able to be flexible with them and understand they may need accommodations. This phased return, if you have some of your, perhaps your church staff right now who are working from home, phasing them back and making sure that they can be socially distanced within the space that they normally work, it's going to be really important. So you might need to not bring everyone back at once, but simply phase that in over time. And then there are going to be some great best practices that we're all going to take away from this. And new practices we put into place. Dr. Board mentioned virtual health. Here at Parkview, we have 4,500 of our 13,000 coworkers right now working from home. That was very different for us. And so we may take some of the new practices in the way we're doing business into the future. So what are you going to keep about the new normal that helps perhaps even engage individuals that weren't engaged before? What's on the slide for you right now is it's not really about the content, it's more about just having a process. So Parkview has, because we have such a large number of coworkers, we had to come up with a process that was going to be the same for everyone coming back into work who were ill, or who perhaps someone in their household was ill. And this return to work process is really important, because not only do you want to keep your team members safe that they're coming back in to interact with, but certainly the members that you're working with, or perhaps, again, other parts of the business community that they're going to be engaging with. It's really important there's a process, they come back to work and you're keeping everyone safe and making sure they're not sick and they have been symptom-free for a period of time. So lastly, I'll share a few of our best practices that we've seen here at Parkview. Now, we've done so many different things, and I'm only going to highlight a few here on the slide, but what's important that we started off by just simply asking. We asked our coworkers, what are your barriers? What are you dealing with? What are your fears? What do you need? No different than you might ask your congregants, what do you need? How do you want to feel safe? What does it mean to feel safe when you're coming into the religious organizations that you're representing? Asking individuals is the most powerful thing that you can do, because you're getting feedback, the voice of your coworker, the voice of your customers, the voice of your members, really understanding so that you can respond and certainly not just react. Flexing benefits, we've done a lot of flexing benefits. And being able to provide child care backup options and elder care backup options. And mental health is also important, because it's easy to forget that everyone is dealing with this a little differently, and their home lives are also impacted very differently. So one size does not fit all. And how are we helping take care of individuals' mental health? Please be cognizant of that, because again, individualization here and what we can bring them to help reduce anxiety, reduce their ways that they're engaging the services that they need. And then finally, just asking members. We talked about that a little earlier, but what makes people feel safe? Using that to in turn provide your members a safe and flexible environment is going to be very important as we head into the recovery and restarting process. I'm going to now turn it over to Dr. Nip.
Thank you, Dana. Hi, everybody. It's Dr. Mike Nip here with a couple occupational medicine insights for you. On this slide, I just wanted to call out a couple things. On the right there, you're seeing something that's from the CDC site on helpful strategies. This isn't something I'm going to go over. It would be a recommendation to seek that out, and it's going to be something you'll be able to link directly to from our site. Jolene in a second is going to talk a little bit more about. I wanted to have you focus here on the orange section for a couple points. So the first one is wanting to focus on wherever issue you're working with on the hierarchy. You want to try and develop a strategy that makes the safe and healthy choice and the optimal choice very automatic and very easy for that person, be it an employee or someone coming into your faith-based space. The second one is to look inward to innovate. You are all experts on your specific workplace and experience, and your end users are oftentimes going to be your experts on finding that key solution or how to untie that Gordian knot. It could be someone who's it's their first day at their job. The third thing is just to be very, very open with your employees and also those guests you're inviting into your space on the extra steps you're taking to ensure their health and their safety. This may be signage outside your building, perhaps an email message, or even as you're coming in, making it very obvious extra steps you're taking, letting them know it might be in between an event a little bit more of a wait because you're doing cleaning of what we're calling high touch areas like the door handles and things like that. And just to let them know what's going on, because we know fear is a very real factor right now. The next slide here is a fairly recent guideline that has come out from the CDC. And again, we'll want you to just come to the site at either CDC's or ours to link and land to be able to look at what should you do to make a optimal decision about reopening and what you should do if you are going to be reopening. So I wanted to share just real briefly, this is a very good slide out of the Toyota document on what they're doing to guide. And so the main thing to look at here is there's many spaces that you may be focused on the first couple, three you think of, but there may be some that you're not thinking of. One of my near and dear to my heart is the coffee maker up there in the top left corner. How can you make the best choice about each space and the things that are there and how people will use it? Sometimes, as Toyota notes there regarding vending machines, it may be eliminating it. But if that's something you can't really do, it's what's the next best thing you're able to do with that. So here's just a couple other areas regarding social distancing. I wanted to call out just real briefly in the restrooms or the bathrooms. One example of making that optimal healthy solution more automatic and easy for someone in your space is even putting the trash can closer to the door so they can wash their hands, have that paper towel, and then contact that high touch surface with the paper towel and not their hand, and go ahead and throw that away and move on. The next slide here is, Jolene will talk a little bit more about this in a second, but this is where you can land on the site regarding your specific industry or sector. Here we see faith-based. What we've done here is try to find the best of the best, if you will, on things that will be very helpful for you if you're just starting your reopening journey fairly far along or just trying to finish up a couple different things. And it's a place to link to good advice on doing those. I just wanted to call out real quick, understanding that many faith-based organizations have things in other, let's say, for example, child or daycare or education. For that specifically, we're going to have a webinar Monday at 9 on education, so please tune in for that. But also, many organizations have other outreach things, maybe a small retail space or a community outreach where they're delivering meals or perhaps doing construction projects or cleanup or something like that. So we'd like you to, if you can, come to the site, review some of those other webinars, or at least look at the slide decks. And hopefully when you land at the Business Connect site, you're able to go to that specific industry for those best of the best links. Having said that, I'm going to turn it back over to Jolynn here.
So thank you, Dr. Nip. So you have all been such a blessing to us, and we want to be a blessing to you. So we're launching Parkview Business Connect, and as we continue to operate in this pandemic, Parkview really wants to help leaders lead. And while you might think of us as healthcare, we are the largest employer in the region. We operate 10 cafeterias, a police force. We have an extensive grounds crew. We have office areas. We have frontline areas. We have auditoriums. So we are learning every day in all of these settings. The dynamics of this pandemic are changing rapidly, which means that our responses may change as well. We're offering free coaching for a safe phased approach to reopen business, sharing what we're doing around return to work, employee safety, HR policies and practices, as well as well-being initiatives. Here's a screenshot of our Parkview Business Connect website. You can connect with our leaders and subject matter experts by clicking on the button at the right. We plan to call you back within 1 business day, and we're really excited about this page. It's going to be a living and breathing document, organized by topic, and we're going to source some of the best sources that we get. As you all come up with creative solutions, please share them with us. We want to stay in dialogue with you so that we can all open safely together. So with that, I'm going to turn it back to John for Q&A.
Thanks, Jolynn, and all the team there at Parkview for providing us that great information. I'll just remind everybody that there is the Q&A tab at the bottom of the screen. We have a number of questions that were pre-submitted, so we're going to walk through those, and then we'll get to the ones that are being submitted now. The first question we have asked about Sunday schools, nursery, vacation Bible schools. Should we be taking temperatures of children? Are cloth masks safe enough for staff and volunteers?
It's a good question. So let me start with temperature screening. So on the surface, it seems like temperature screening would be an easy way to help minimize risk of people who might be infectious coming into a group setting. However, there's some very important limitations and cautions to recognize. First is that we know from the medical literature and from our clinical experience in our health system is that upwards of 50% of patients that are diagnosed with COVID-19 may not have a fever at time of onset of their symptoms. So this is something that's been recognized in medical studies. We have seen it clinically. A patient may have a cough, muscle aches, sore throat, but may not yet have a fever. And so a fever is not in and of itself, lack of a fever does not rule out the possibility someone may be ill with COVID-19. So just temperature screening alone is going to miss potentially infectious individuals. Second is, how do you actually, and when you think about the practical aspects of doing temperature monitoring, you have to screen everybody. You'd have to screen every child or student. You'd have to screen every staff member. You'd have to do it every day. If you're going to screen somebody, you have to get within 6 feet of them, which means that the person doing the screening would have to be wearing appropriate personal protective equipment. Depending on the method used to measure the temperature, if you're using a non-contact like an infrared handheld temperature scanner, those do not have a level of accuracy that would be adequate for this purpose. They're plus or minus about 2 degrees Fahrenheit of accuracy, so they may miss people with a low-grade fever. And there's some important considerations if you are an employer requiring temperature screening for employees. So that actually becomes protected health information. And so if it's going to be used for employment decisions like ability to be at work, that information has to be handled in a particular way. It has to be equally applied. There have to be clear policies around it. So temperature screening is something that is more complex than it may first appear. Masking is something you have to look at the situation that you're in. And if you are able to apply other aspects of the hierarchy of controls, so elimination, administrative controls, those types of things, masking may not necessarily be required, but if you're in a situation where you can't maintain social distancing or other factors, then a cloth mask for what we call source control might be an option. So source control meaning that I'm wearing a cloth mask or face covering to so for my coughs and sneezes don't get on other people. So the mask isn't for me, it's for everybody around me. And if you're using masks for source control, it's something that everybody in a room has to be wearing a mask to optimize the benefit for source control. If only a third of people are wearing masks, it's not very effective. So practicing good hand hygiene, making sure that people who are ill don't come, those are really some of the most important things in addition to social distancing. So, and making sure that you're cleaning high-touch surfaces, those types of things. Masks are not appropriate for children under 2 years of age.
Can we talk a little bit about how we can keep our older adults and vulnerable members safe?
Sure, it's Dr. Knipp. I'll take that. And again, Dr. Bohr did a great job explaining vulnerable is more regarding course of illness versus who is susceptible. What I've seen in other places, for example, grocery stores are having special hours. I think they're calling them senior moments to go out and give them an hour at the first hour of the day to do that. Would think a faith-based organization could possibly look at a specific service for those folks. There's also the point on there about, again, goes back to limit how many people are going to be in the space. If you're used to having a full choir, is there a way to make that one musician, perhaps just an organist versus having a full choir or ensemble to do that? Virtual services for also older or vulnerable members, I think has been a very creative and effective solution. It's not the connection we're used to, but I still think it's able to connect very well through that.
Yeah, obviously a number of different ways that religious institutions handle communion, but can you talk a little generally about how we can partake in communion safely?
Sure, I think the biggest points are there on the slide that we really want to eliminate if anything that is shared, no shared drinking from a cup or a bowl or a tray. This would, to sidelight a little bit for a donation plate, we may have to have different solutions for that as well, because that would be a shared high-touch item. And again, I don't have the answer to say, are there readily available disposal prepackaged items to be used for this part of the service? Someone on the call may have that key answer and could share with everyone else. And additionally, when you do have serving, it's looking at the higher controls going to source control, having that person be masked if they're going to be serving and be in less than the 6-foot social distance with the folks at the service, as well as having gloves on at the same time.
To highlight Dr. Knipp's point, I think it's that single serve, single use type of solution that is best whenever possible. So, small individual plastic disposable communion cups and individual servings of the bread, for example, which are prepackaged appropriately and can be individually distributed to parishioners safely, can allow that with a greater margin of safety.
I'll call out, thank you, I learned something today. There's been no less than 4 different viewers. Thank you for chiming in with where that is. If anyone does maybe have a website, could they possibly post that and we could get that out to everybody?
One of the big questions we have is how can we gather safely in large numbers? Is it 100 people, 50 people? Does the size of the building matter? I know in some of the other webinars we've talked about, there's been questions about number of people per square feet. Can you address that, please?
So this comes to looking at your space and how many people can safely congregate in a space is going to depend on the size of your space and the configuration. So if the church that I attend has a very large auditorium that can seat, 1,000 people, I certainly wouldn't want to see 1,000 people in there in the full capacity, but given that it's a large space, you may be able to have people sitting at every other chair, every third chair, to allow that 6 foot of distance. Now, if you have individual households, so if it's me, my spouse, and my 2 children, we all live in the same household, we're close together every day, all the time. I can tell you right now, if one of my daughters is sick, I'm going to get it if they're living in my house, unless I take those precautions immediately. So families might be able to sit together because they're going to drive together to that place in the same car, but anybody who is not living in the same household and already aggregating needs to be separated by at least 6 feet. So you really have to look at your worship space or meeting space and really plot that out and say, what can we do to seat people appropriately 6 feet apart? The other thing to think about is engaging your faith community. So it's going to take quite a bit of effort. It's going to require doing things differently. So how people file in and out of that space so that they maintain social distancing. You may need to enlist volunteer effort to do cleaning of high-touch surfaces before and after a meeting or service. And fortunately, those of us that participate in churches and other faith communities often are willing to pitch in and help if someone gives us guidance, and then you have those cleaning materials on hand, or you may want to identify a crew that can help on a volunteer basis to implement those additional safety measures.
The next question is one that people are thinking about and kind of came up earlier. How should we clean before, between, and after our services?
Sure, that's a real common question and a good one to touch base on. So again, to have a good cleaning policy in place and follow that, probably having to do it a little bit more frequently. There are resources out there, what the FDA has supplied on which cleaners are appropriate and effective. And again, the second point there, it's taking a fresh look at your space and what you have, because there will be high touch things you wouldn't have thought of, but for example, hymnals or other things may need to be removed, or perhaps you're able to, after a service, clean them, and then as each group comes in, they, one is cleaning from them and that's handed to them. Just different ways of doing things you've done before. The other example or suggestion we had is possibly having a video up with the words to be sung with the various hymns. So I think it's just following those basic cleaning guidelines, and like Dr. Board was mentioning, it may need to be expanding that volunteer base to come in and clean a little bit more frequently.
One of the good questions is we mentally need some normal. Can we meet in person without everyone, including everybody being in a mask? And I know it kind of came up earlier about your environment, and I know that you all are separated by 10, 15 feet when you're not on the screen. So you've really used that separation. Can you address this question?
I think honestly that above and beyond the hierarchy of controls, I think it's sort of common sense. So if you're meeting one-on-one with a person, we've talked about this in some other webinars where you have those one-on-one interactions between a person and a client or patron, and the question is there a way to have that meeting safely where you can maintain that social distancing? So if you can maintain the social distancing, not shake hands, perform good hand hygiene, good respiratory etiquette, remain 6 feet apart, masking may not necessarily be required, but I think the key is taking those in other steps, what we would call the administrative controls, and maybe even some engineering controls to help maximize safety without the use of just relying on personal protective equipment such as masks or gloves.
One of the questions obviously is when can we open up our houses of worship? When can we get back to service? Who regulates and enforces any direction on whether or not a church is open? Obviously, the governor's going to come out with some remarks today at 2:30 that will hopefully address this. Can somebody touch on that?
John, I'll jump in since no one else is. This is Mindy. To date, following all of the other governor's orders, there has always been some guidance that came out a day or two after the orders were issued, indicating how the enforcement piece worked. And we anticipate there'll be something similar to that after these orders. It just won't be immediate. However, we have heard that it would potentially be something along the lines of a hybrid enforcement model where likely health departments would be tasked with ensuring compliance of those that they regulate, the ones that we license and permit already. And then there'd be other agencies that the governor may task, as he has so far, with the enforcement for the rest of the type of entities. And he had sort of blanketed those under OSHA and then the ATF, or the Alcohol, Tobacco, and Firearms Commission prior. We're told that might be something similar to what continues. That's what we know now.
Thanks, Mindy. I appreciate that. Now, I'll just remind everybody that the Q&A tab down at the bottom is open if anybody has a question as we start to get through kind of the questions we had going into this. So please, if we haven't covered something, please feel free to submit that question. You kind of touched on temperature checks earlier when you were talking about Bible study and nursery programs. Can you talk about, should we be taking temperatures as people come into church?
Well, as I mentioned earlier, although temperature checks seem very simple on the surface, there's a lot of important limitations and complexity underneath that. So many people that are ill may not have a fever. If you're going to do temperature checks, then somebody with personal protective equipment has to be standing at the door and has to screen each and every individual. If you're in a church or religious faith setting, this is on a voluntary basis. You can't compel people to have a temperature check, and you have to think about that consideration. So really, honestly, if we think about the hierarchy of controls, my church has been offering online services. So we have been sitting on the couch at home as a family every Sunday morning, and we have been engaging in worship at home with our church live stream, watching it on a television. And that is 100% effective at protecting other members of the congregation. So thinking about those virtual options is always good to consider. So really talking more about making sure that your faith community knows, don't come to that worship service sick. Practice hand hygiene, practice social distancing, stay apart, don't shake hands. If people wish to wear a cloth mask, that certainly can be helpful for source control and encouraging that if it's appropriate, particularly in areas where social distancing is more difficult. So thinking about all those other measures and not just relying on temperature screening alone is what we would suggest.
Sorry, I had myself muted. This question is about outdoor gatherings, and it probably depends on what the governor comes out and says, but if we practice social distancing and we do it outdoors, is that a safe environment?
This is Dr. Knipp. I think you hit nail on the head. We have to understand from the governor what the expectation is going to be. I think weather's going to be a factor, but I think a solution that I guess that's outside of a vehicle, but there also could be a strategy where you might have folks in their vehicles, and you have someone, this is the drive-in movie is coming back in. That could be another strategy. I think we're just all kind of waiting for some of the direction on where we could go based on any further guidance the governor is going to let us know about here very soon.
Is there any guidance you could give folks on, kind of a good frequency to clean high touch areas like bathrooms and sinks versus rooms that are maybe used once a week?
Sure, that's a great question, John. I saw there's a couple about that. I would say, and I believe we have something on our site, there's many good guides on appropriate cleaner plus area plus frequency of cleaning. I agree with the person who submitted the room or table once a week you use. Obviously, I don't think that would be something I would clean as frequently as I would a bathroom. The other viewer's question on there asked about, do we need to clean the bathroom after every person? I don't really think we need to get to that point. I think maybe several times a day based on the best guidance that is out there. And again, we're front loading the users of our space, including the bathroom, to say, hey, please, for your additional steps for your health and safety, practice these additional steps. And we're back to making that automatic and easy for them, providing hand sanitizer, the trash cans closer, paper towels they can use to contact those high touch services. Good questions though.
Any insight on how we could handle folks who don't want to follow our procedures, whether it's wearing masks or social distancing?
Well, I think really communication is the key. So as a congregation, a church, a faith community starts to reconvene, is really communicating the safety plan and expectations to your membership early and often. So, putting signage on the door, putting information in emails and other types of online bulletins, etc., and having announcements at the beginning of the service to help encourage people to follow those appropriate safety measures, social distancing, etc. So it's something where I think using a lot of communication and really emphasizing this is not just for your personal safety, but it's for the safety of the other people in your faith community. And you certainly don't want to be someone who's going to spread an illness around to someone else who might be vulnerable. And we're all in this together, and we all have to do our part. And so really appealing to their, duty of thinking about others really helps people understand the why.
Yeah, that might even include just making sure that people understand if they are sick, don't come to church. Kind of the same thing as if you're sick, don't go to work. It's that communication piece is probably just needed to make sure that people understand this is for the greater good. Any thoughts on, you talked about choirs and kind of eliminating the large numbers up at the front. Any insight on just traditional singing or verbal responses to pastors? There's obviously that involves singing and opening your mouth, and we all know that that's a potential spread. Is there any thoughts on that?
So this is Dr. James Cameron. I'm on the Board of Health, and that actually raises an interesting point just with regards to worship. Obviously, singing and the congregational responses to the pastors is a huge part of the worship service. But unfortunately, we do know that the virus is spread through simply talking, and so that if it's possible for the purposes of worship that you do have just either an organist up front for that time, and maybe have one person, one of the elders of the church, responding to the pastor, that could then possibly satisfy the need in place of or in lieu of the congregation.
I think we'll take one last question here, and it's a question about mask etiquette and kind of best practices. If we're asking people to wear masks, but then offering them communion, they're going to be touching their masks and potentially creating cross-contamination issues. Any guidance there?
Well, keep in mind that generally speaking, if someone's wearing a cloth mask or face covering, that is for source control, right? So that means that the mask is to protect the people around me, not just me personally. So the goal there is have the mask up, because if I cough or sneeze while I'm waiting to receive communion, I don't have my respiratory secretions getting on me, getting on other people or the environment. And so if I get ready to partake of communion, I carefully pull my mask down, partake of communion. It's all single serve and it's clean stuff. I put my mask back up. That's okay. And then also I'm practicing regular hand hygiene. That's really the key to it. In different, sort of more healthcare settings, contamination of the outside of the mask. If I'm a clinician performing certain types of procedures where fluids can be on the outside of the mask, then contamination of the outside is more of a concern. But when we're thinking more in this context, the mask is for source control, and it's all about social distancing, hand hygiene. Pull the mask down, take your communion, pull it back up, keep your hands clean.
I want to thank all of our presenters today, all of the everybody that helped answer the question and answers, as well as all of the participants. I want to thank our partners in this, Parkview Health, the Allen County Department of Health, the Northeast Indiana Regional Partnership, and Greater Fort Wayne, Inc. I want to remind you that parkview.com/businessconnect is available to you. Please utilize that opportunity to submit questions, and they'll get back to you in a 24-hour period. You will be receiving an email with a survey, and then you will also be receiving an email with a link to a recording of this webinar, as well as a copy of the slides for you to use. Well, thank you and have a good day.